Okay, so thank you to everybody and welcome from my side. Thank you, Mariano, for the introduction. Again, I would like to thank our sponsor of today for this technical forum about the treatment and the crossing of calcified lesion, especially to ASAHI, INTECC, and Shockwave. And we have prepared, of course, some material for discussion to be, as usual, provocative and to create, I would like to say, some topics of discussion and some basis for a particular and delicate process, which is the crossing, the calcified lesion crossing. So I would like to start with the recorded case. The title is Above and Below the Knee One Wire Option. So this is my disclosure, and this is the recorded case number 4 of Global CLIC Global. The patient is a 92 years old lady with diabetes, of course, hypertension, critical ischemia, and a lesion in the apex of the second toe. It's not a huge lesion, but it's very painful. And the treatment and the study is this one. You can see here the CO2 angio. There is a huge occlusion in the distal SFA popliteal tract and a very bad condition in the foot with the presence of some arteriovenous fistula. I would like to stop the movie a little bit in this area. Sorry, here. Okay. I'm not prepared. Come on. Okay.
More.
So there is a lesion in a particular area. So the length is quite enough to be challenging. When we will see the aspect of the lesion, so the severity of the calcium, we have to ask to ourselves which could be an alternative approach, of course, because we decided to cross this lesion with a wire, and of course it's not the only wire available, but it's not the only approach available, and that's why I would like to discuss with Mariano and you all about this strategy. Beyond this lesion, there is a complex occlusion in the anterior tibial artery, and particularly in the foot we have a quite desert foot, especially in the forefoot. We don't know with this angiography, with this diagnostic phase, the real condition of the foot, because the still effect of the fistula. So for this procedure, we have chosen this particular wire, the ASAHI Albert 1/4. Well, for every single colleague and friends who know our normal way of working, starting with the 1/4 is not common in SFA in our experience. Despite in session of CLIC, we discussed about this topic, why we cannot use directly a 1/4 in SFA2.
And another comment is that even if you, me also, never start till today with an 014, almost never start with a CTO guide wire.
Yes. So the first question is, of course, I decided, because of the aspect of this calcium, the aspect of this lesion, the length of the lesion, the length was not so huge, about 10, 12, maybe 15 centimeters, but not 30, not 40. In my mind, it's always difficult to remain in the true lumen of a lesion when the lesion is really long.
Absolutely.
Despite of course, we can change the radiological projection in order to follow, always follow exactly the advancement of the wire and check that the wire tip remains in the middle of the calcium. But when the lesion is really long, the probability is to go out and subintimal and coming back into the true lumen and go out again, probably we don't know really what's happening to the tip of our wire. But I invite you to follow this wire. This wire is a 1/4 Albert ASAHI. I remember you that this wire is a CTO dedicated wire, pre-shaped. Later we will discuss and we will see better this the tip of this wire and the construction of this wire. But there is a very, very short bend, few millimeter, probably is 1 millimeter, 1.5 millimeter, pre-shaped, and the concept is to find with this microcone shaped tip to find the potential microchannel in the middle of the occlusion and try to remain in the true lumen of the occlusion. But we have to follow the behavior of this wire. You can see here, I try to rotate the wire. If you can see the movement of my hand, I try to rotate the torque. So the technique is the drilling technique. I would like to come back a little bit. You can see here the wire is out of the vessel.
Yeah, it is clearly out.
Clearly out of the vessel. You can see the stiffness of the wire when I try to apply just a little bit of force, strength to push the tip in the proximal cap. The flexibility of the wire is very poor. So the first approach is to find the first microchannel or the first door in the proximal cap. When we are in the middle of the calcium, you can see here I try to support this wire with a microcatheter, and I would like to remember that this first microcatheter is the new Surgent support catheter from iVascular. But the optimal technique should be to keep and maintain the tip of the micro catheter or the supple catheter very, very close to the tip of the wire.
Right?
In this moment, probably the wire succeeded in re-enter in the distality of the wire, of the artery. I can stop a little bit. If we try to define the position of the system in the middle of the calcium, is not in the middle. So probably we are in the true lumen, but we cannot be sure to be always in the true lumen. We are very, very close to the external edge limitation of the calcium in that area, but probably we are in the true lumen. I don't know if there are questions about or concerns of from the audience. We are very welcome to try to answer. What's your idea, Mariano?
I have a comment and a question for you. The first comment is that was clear, as almost always happened, was clear to penetrate the proximal cap. But the nice thing of this guide wire, following the video, was that the time you penetrate, you enter the proximal cap, was very difficult to went out. I mean, the guide wire navigate even when you push it. It follow, yes, not always in the middle, but because probably it finds a micro channel that was not always in the middle of the occlusion,
yeah,
but was in the lumen. I think almost clear it was in the lumen or finally re-enter suddenly. So I think it's an amazing guide wire, because with CTO guide wires you could have difficulties to enter, and in many cases you enter and finally finish out of the vessel. This guide wire, created with a pre-shaped concept, created to navigate and to find the microchannel, seems to do the job perfectly. The question is, I'm not completely sure, but following the video seems that in some way the tip, the tip of the guide wire elongate a little bit. It happens or not?
No, I'm not sure about
the
this.
Coil.
Yes, I'm not sure about this. The impression is that the resistance of this tip is higher compared to the most of the CTO wires, where you have the tendency to have a break, to have a damage in the tip, and many times that there is the risk to lose exactly the very, very distal tip, very, very distal part of the tip of the wire. So the feeling was that it is a resistant wire. My impression, so the velocity, the speed of this video, of course, is not the real one. I try to reduce the time, because I spent probably more than 20 minutes to cross this occlusion. Many attempts. It was not easy to understand the direction, to change the direction, because the wire maintains the bend in the tip in the middle of the occlusion. So the great capability of this wire is to maintain the possibility to change the direction, and the torque is 1-to-1, so you have to be very, very delicate in the manipulation, because if you rotate too much, sometimes it's difficult to change the direction and to proceed in the new direction you have chosen. So if I can say, it's different from, for example, from the Astato 20. To speak about a wire of ASAHI. Despite the less aggressive tip, so this tip is 12 grams versus 20 grams of the Astato, the penetration power is quite good, and the possibility to change direction probably is higher compared to the Astato 20 wire. But for me it was a little bit difficult to learn how to move this wire. I mean, wire, the name is guide wire. You have to drive to guide the wire. It's not the wire going exactly always in the proper track, in the proper path.
Well, but this is a concept, probably the first concept I learned from you, that you never push the guide wire, but that you drive, you guide the guide wire.
Yeah.
So maybe this is a new generation of guide wire that need to be
Yes,
guided.
probably it's, like a new car with Shannon is driving a
In the opposite side.
a self-driving car. So, sometimes we have to try to reset our connection, hands, brain, when we have new devices. And for me, this was a good test. With the same wire, it's not always possible to do everything. For example, in this case, I decided, you can see here the bend in the tip.
Still like new.
Okay. And this tip, this bend, this curve is very well maintained in the middle of the calcium. So now I would like to maintain this wire and drive the wire into the anterior tibial artery, which is severely calcified too, and cross the occlusion from the middle portion to the distal part of the anterior tibial. The surgeon, so the catheter was short, so it was only 65 centimeters, so not enough to follow the wire into the tibial vessel. Have you seen the wire could approach the curve of the anterior with very, very few difficulties. So this is a good aspect because
it can navigate.
Yeah, in the most of case, and look how easy is going in the middle of the calcificated vessel. Now there are some difficult and challenging passages. Again, we have to drive the wire and try to maintain the tip in the middle. I would like to
This
stop.
This is a new guide wire, or is it still the same?
No, the same.
Perfect.
The same.
So
It's
the
the same
resistance,
guide wire since the beginning.
the resistance of this 014 guide wire is incredible.
Yeah. I don't know if I can underline this aspect, but sometimes when you are using aggressive wires, so CTO wires, and the tip of the wire is going out of the vessel, especially in the calcium, when you decide to retrieve the wire, you feel resistance, like the tip remained entrapped in the calcium. So you pull, but there is resistance.
Yeah.
With this wire, this kind of feedback was very, very poor. So I could not really have the impression to have a tip entrapped. So it was quite easy to retrieve the wire with very, very few resistance. And this could be related to the coiling, to the construction of the wire, and probably to the pre-shaped bend, which is not made by us.
Yeah, clear.
But it's always possible to create a second curve if we want in this wire. Shannon, do you have experience with this wire?
Yes. So I use the Gladius usually as my first wire. I know you've started with Halbert here. Gladius is usually my first. Halbert is very good. I think, Marco, one thing we probably haven't spoken about is the importance of using the microcatheter with this particular technique to assist in crossing such tough lesions. And I'm curious as to whether you change to a longer microcatheter or a balloon when tackling this distal CTO into the foot.
No, I try to support the catheter because this support catheter was short, was 65, so I shift to the Boston. Come on, the microcatheter from Boston Scientific.
Yeah.
I'm sorry, but Alzheimer is
It's not the
with
name.
me.
It's not the name of the microcatheter.
No, I can with the three markers, and I can show you. The difference is that the surgeon was curved, so is bended, while the Boston catheter is straight. You can see here arriving probably the microcatheter coming, yes, with the three markers.
Is that a quick cross catheter?
No, it's not a quick cross.
No.
Should
No,
be
it's from Boston Scientific.
I can't remember the name.
Sorry, not Trailblazer, is
Trailblazer is from Medtronic.
with the
TrueCath?
no
Ra.
with the air. You can see here the occlusion and the advancement of the wire into the middle of the vessel. You can see how the bend is very well maintained in the middle of the calcium.
Rubicon.
Rubicon, yes.
Rubicon.
Thanks, Anna.
Okay. I would like to stop here. Have you realized the movement of the wire is very slow? Normally, when I use a more aggressive wire, like the Sato 20, the rotation, the speed of rotation is higher. But when I tried with this cutter to rotate, the efficacy was very poor. If you try to have a very slow motion in the tip, so you try to use the one-to-one torque control on the tip, so the effect is to exactly rotate the tip towards the direction, the new direction you want. Probably you create the ideal way to advance the wire. This is my my feeling with this wire. So I had to modify the technique. You look because the advancement is very, very slow.
I remember when I tested, it happens in Abano and also now in Cotignola. I remember I also changed the technique. I never drill 360, but what I did was to go up and down, so right and left, half and half of the movement, replicating what you are showing there.
Yeah.
So again, it's a new guide wire that need different technique.
So the speed of advancement is very, very slow. Of course, it's a long occlusion, it's calcified, but normally the advancement with an Astato 20 is faster than this, but probably because the aggressivity of the wire is not so high.
Faster, it depends, because with Astato 20 maybe you faster finish out multiple times. I mean, this guide wire cross always.
Look now the wire, the movement of the tip clearly is good, is no resistance. We are probably already in the true lumen again, and we have a new occlusion here with a very, very thin pedal artery. Is not only calcified, but it's very thin. It's no more bigger than the wire.
Yeah, it seems to be bigger than the wire.
Yeah.
Smaller than the wire. The wire
Very
seems
small.
big than the artery. So for sure it's collapsed, but it's very, very small.
Okay, we arrived here. We are very, very close to the arch. It was not possible to advance the Rubicon beyond the occlusion. So these are a predilatation in the top and in the middle of the artery. In order to predilate with the single marker balloon, it was the smaller balloon. This is the predilatation in the occlusion of SFA, just to remove all the friction and to advance a long sheet in order to try to improve the capability to cross with the balloon
Wow.
after this dilatation. You can see here the resistance of this lesion. This was a high pressure non-compliant balloon, and finally we could arrive in the pedal artery 2.5 high pressure, and this is the final result, not the final, but the acute result. This is a very long balloon, 300 in length, 3 millimeters, and the treatment of the popliteal and SFA with the 5 balloon. CO2 angio, and the final aspect of the foot.
Wow.
With
Very
the
nice. Wow.
2D perfusion angio, quite good, with a good significant improvement in density. So this is the direct comparison of the wire we described. So we use the Albert 1.4. You can see here the difference compared to the Astato 20. The Astato 20 is a tapered and is contour tip. Directly the core of the wire arrives exactly in the tip of the wire. The same for the Albert, but we have a coil. It's not tapered. There is a microcone covered with the coils, and there is we have the different feature here. 20 grams for the Astato, 12 grams for the Albert. But what I want to show you is the bend, the mini pre-shape armor tip. This probably is the real the most important aspect of this wire. This curve, this pre-shaped, is capable to approach microchannel and follow microchannel, and you can see here the possibility, having the possibility to maintain the shape of the wire in the middle of the occlusion. Of course, if you need, you can apply, you can perform another curve, a second curve, so create a double curve, like sometimes we used to do, just to approach very angled branches, or in the foot, for example, the communication from dorsalis pedis into the arch sometimes is very angled, or there is a coiling of the artery, and so it's possible to create a second wire. So in conclusion, the Albert wire is a pre-shaped CTO wire. The micro-shaped tip is enough to redirect the wire when we need to redirect. Despite the less aggressivity of the tip, my advice is to be prudent, as always, with this wire, because as you could see in the first occlusion in the popliteal tract, I went out several times, and it's really easy to go out with this wire. Despite it's less aggressive compared to the Astato 20 or 30 or other dedicated CTO wire. The support and tip resistance are very good. One wire for multi-level disease. So I found this advantage, because I could use just one wire to cross all the tract from the beginning of the procedure to the end of the procedure. The one-to-one torque is really more than evident, because you turn and you can see the tip of the wire moving exactly in the direction you want. And of course, at least in my experience, try to achieve confidence before approaching complex cases, because it's not easy to have an immediate confidence with this wire, at least in my experience. Thank you.
Thanks, Marco. Well, as always, impressive case and impressive presentation. We have a question from the audience that is quite related to the case. The question is, how do you choose the balloon size in calcified vessels?
So, this is a very nice question and not easy to answer in a univoc way. As you probably realized, at least in peripheral procedures, I mean lower limb procedures, we are interventional radiologists, but we have Shannon, who is a vascular surgeon, and probably many friends cardiologists, but we don't have a real system, a scientific system to choose the balloon size. In Italian, we use the term occhio e croce, which means eye and cross. So more or less, in my experience, when I see that calcification in that area, I can compare the size of calcification to a balloon and say, okay, probably it's 3, probably it's 2, probably it's 6, but it's not scientific.
No, not too much.
So when it's possible and when I have the probe, I can use the IVUS. If I have the impression, well, let me explain well this topic. It depends on the outflow, basically.
I think this is the first thing.
So we know that more or less tibial vessels are 2.5, 3 millimeters. But if we do not have enough vessels in the foot, so if the outflow is not ideal, it's not useful probably to reach the real size of the vessel. I mean, if we have 35 centimeters of anterior tibial, 3 millimeters, and we do not have enough vessel to receive the blood, we will achieve a very, very low flow.
Pulse flow.
Pulse flow, and this condition is very much prone to lead to a thrombosis. So probably it's better to maintain a thinner vessel with an acceleration capable to achieve a better perfusion in the distality. So the first is try to evaluate the outflow in the foot. If the outflow is good, you can reach probably the real size of the vessel. Then, when I have the possibility, economical possibility of course, I can use the IVUS. The IVUS surprised myself because in the most of cases, in my mind, my choose, my first balloon was 3, and the IVUS told me the size is 3.8. 3.8 is almost 4. So the IVUS size is always bigger than your idea. So if you could evaluate with IVUS every single patient and every single vessel, probably you would improve the size. You oversize the balloon at least of the half millimeter or 1 millimeter, and probably the clinical outcome of that patient could be better. This is the my answer. In the real world, we cannot spend so much money for IVUS, so the most of times is yes, probably it's a 3 because the size of the calcium is 3.
Marco, I wanted to say that this case that you just did was a very nice example of sizing the balloon, because on your initial control angiogram, the outflow looked terrible. There are no metatarsal digital arteries. It almost looks like a blind ending dorsalis pedis, maybe into an arteriovenous fistula. And yet, after you performed the crossing and the initial predilatation, suddenly you can see so much more outflow in the foot. And I think that probably gives you the confidence to then dilate that tibial artery to a larger size, knowing that you've now secured very good outflow that maybe on the initial angiogram you did not know was there.
Yes.
Yeah, exactly.
Correct, Shannon. Exactly, it was exactly like this. So that's why I underline the importance to evaluate the outflow. When you have an occlusion, a long occlusion, and sometimes you, the aspect, the diagnostic is, okay, it's a desert foot. So it's difficult on the base of that diagnostic angio to decide strategy, balloons, sizes. You have to arrive as distal as possible, check the outflow, realize that there is outflow or there is not outflow, and then you can define the progression of balloon sizing. So you could see I tried to predilate. We start with 1.5, 2 millimeter, 2.5, but if there is the outflow, you can arrive at the final dilatation, proper dilatation, very close to the real caliber, the real size of the tibial vessel.
Yeah, just to do my point of view, I fully agree with both of you, but another important rule is to do a super selective angio to check the outflow, because multiple times or in multiple cases like this, we suspect a desert foot or a desert forefoot. And finally, when we are lucky to arrive there, remove the guide wire, inject through the microcatheter or through the balloon, we can inject a nitrate or vasodilators, and finally we realize that we already have this outflow. And another important rule, as Marco said, is the pre-dilatation, because it gives us the impression that this vessel can be dilated a little bit more, the outflow can take off this volume of blood or just no. So this is a good rule or a good message to dilate the calcified arteries. If you don't have IVUS or if you don't know the good diameter, start with a small balloon, start with a 2 millimeters from the arch into the anterior tibial, check, look the differences, and going step by step. Finally, in most of the cases, you will achieve a good result.
Shannon?
Yeah, look, I completely agree there with Mariano. I think, I think that this point of, when you do the initial angiography before crossing the lesion, I think you, as an interventionist, you can be disheartened into thinking you're dealing with a desert foot. And then when you cross into a target trunk, like the lateral plantar or the dorsalis pedis, exactly as Mariano is saying, you make the injection and suddenly you will see, the lateral tarsal appear, or you will see some digital arteries appear. It is amazing how many of these vessels are sort of hiding. And the only way you will know that you've got the outflow is by actually getting down intraluminally into the foot and making an angiogram to find them. And I think this is a very, very important point, that even before considering DVA or any treatment like that, it's very, very important to look at the native arteries that may be hiding in the foot.
Yeah, and I think that another technical important point is the type of the contrast media you are using, because the first angio done with CO2 allow us to understand that there was something, small distal dorsalis pedis, but some metatarsal branches. The time you repeat it with iodinated contrast medium, as everyone knows, the iodinated contrast medium in most of the cases mixing with the blood is diluted, and when it arrives to the small arteries, distal small arteries, sometimes it's not able to contrast. This small arteries completely different with CO2 that is not mixing with the blood, so it's a low density, so can arrive as distally as possible. So again, you in these cases you always need to do a super selective angio to check, and sometimes use the proper contrast median allow you to suspect that you have already something distal.
A question for Shannon. But for example, on the base of this of the first diagnostic angio we did, supposing the patient could be scheduled for a distal bypass.
Yeah.
With that foot, could you think the patient could be eligible for a distal bypass, or are you?
Well, let's say the patient was fit enough for a bypass. I think that from what I saw on that angiography, the dorsalis pedis did not appear to be a very big vessel. It was very, very small.
Yeah.
And I think that if we were to attempt an anastomosis onto that vessel, the bypass graft would probably not generate enough flow because the outflow appears so poor. And so it would probably thrombose very quickly after joining it up. Whereas I think what you have done in this procedure is you have dilated the dorsalis pedis artery. You have dilated the target for the bypass. So this is the thing. I think that bypass surgery's got a very limited role in that we can now go and dilate the target tissue, the target vessel, with endovascular techniques. You cannot do that with open surgery. Maybe if you have a hybrid technique where you land the bypass graft and then you go down, with a wire through the bypass graft and dilate the outflow, the dorsalis pedis, and its branches, then yes, sure, maybe you can do a bypass. But otherwise, I think it would be a very limited option.
Okay.
Okay, there are no any other questions from the audience, so I think we can continue with.
Okay.